A very good morning, everyone. I'll be presenting my case on Bleb revision as a sight-saving intervention in a patient with chronic encroaching filtering Bleb. So brief introduction, filtering Blebs are key to trabeculectomy success. Few complications, which includes leaks, infections, hypotony, and encroachment of overlying Bleb. The progressive encroachment of filtering Bleb onto the cornea may compromise corneal health and can lead to a visual improvement over time. So the purpose is to present this array as of chronic encroaching Bleb with intermittent aqueous leakage, which highlights that the ultimate surgical revision which is done in this patient as a sight-preserving intervention. So this was a 63-year-old male from Delhi. He was asymptomatic otherwise. He was a known case of glaucoma, open-angle glaucoma with a right eye advanced glaucoma, left eye moderate glaucoma with both eye phakic, and he was status post-op trabeculectomy in both the eyes. So clinical findings in the anterior segment, the best corrected visual acuity in the right eye was 660, and IOP was 14 millimeter of mercury, and the left eye was 6/12 with IOP of 10 millimeter of mercury. This is the picture of the right eye functioning Bleb, which had advanced glaucoma and visual BCV of 660. And this is the picture of the left eye, which shows the thin avascular cystic Bleb, which is encroaching up to the pupillary margin. And there was history of intermittent aqueous leak present, but the patient was being managed conservatively with antibiotics and bandage contact lens as the patient refused surgery. So this was the picture of the left eye Bleb picture in 2024, and the below a picture is was taken in 2025. That was in January. So as we see the encroachment was progressive, and we also saw a few choroidal striations on OCT macula. In the further slides, I'll be showing that. So this is the photo of the right eye advanced glaucoma, left eye 0.6.7. The left eye OCT macula showed few choroidal striations as well. So this is the visual field of the patient. The right eye tan-2 shows the advanced glaucoma, and the left eye has inferior arcuate scotoma.
Can I request the speakers to kindly stay back? We'll have a group photo at the end of the session. Yeah, please continue.
Sorry. So this is a surgical video of the patient. When we finally counseled the patient about the need for the surgical intervention, as the Bleb was encroaching and there was a history of intermittent aqueous leakage also. So what we did, that the conjunctival dissection was done, and the part which was encroaching of the cornea of the Bleb was excised, and post which we sorry. So I don't know what happened. Sorry for the video. Sorry. So then we saw that after excising the anterior part of the Bleb, we saw that there was aqueous leak which was positive. And then we completely opened up the Bleb for full Bleb exploration was done to find out the area of leak. And we found that there was a scleral leak from the side, temporal side of the scleral flap. And then the two scleral flap sutures were given, two 10-0 nylon sutures, and AC was formed with intracameral air, and the conjunctiva was meticulously closed, followed by relaxing incisions which were given in the end to prevent any shortening of the conjunctiva and any retraction in the future. So the post-operative day 1, the visual acuity was 612, and the IOP was 20 millimeter of mercury with well-formed AC, and there was no positive leak on sedals. And there was on further follow-ups, now the patient had improved to 6/9. IOP had reduced to 12 millimeter of mercury with intermittent ocular massage, and then no anti-glaucoma medication. The Bleb was stable, and there was no recurrence of leakage or encroachment noted till date. So as we know that encroaching Blebs can induce astigmatism, corneal compromise, and recurrent leaks. So conservative management is suitable if stable and there's no hypotony, whereas if there's progressive changes threatening vision, the revision is warranted, and one-eyed patients, they need timely proactive care. Thank you.
Very nice case, Dr. Barkha. What are the conservative methods you tried in this? There was only, you found that there was intermittent leakage,
Yes, sir.
which how did you detect? By seedles?
Yes, sir. Seedles.
By seedles.
Yeah.
So what are the conservative measures that are tried,
So
and what is the indication of surgical intervention?
So we tried. We were intermittently trying with bandage contact lenses and topical antibiotics to prevent any. So we had counseled the patient for surgical intervention, but patient was not willing as he feared surgery because he had only the seeing eye. So we finally counseled him because the bleb was encroaching. Since we compared the picture from the 2024 to 25, so bleb had increased up to the pupillary margin, so that we counseled him that since it is encroaching, even if that time leakage was not there, it was stable, but we had to take the patient for surgery, and on table we found that there was active leak present.
Okay. So your primary indication in this case was encroachment of the bleb onto the pupillary.
Yes,
Otherwise, you can, besides bandage contact lens, you can try aqueous suppressants.
Aqueous suppressant.
Yeah, you can even try systemic doxycycline or azithromycin. That is also mentioned in the literature.
Thank you.
And measures even like collagen cross-linking has been described in the literature. Only if there is a leakage or there is hypotony, then surgical intervention is required, depending on whether the defect is large or small. If it is small, then conjunctival advancements can be done, but if it is large, then conjunctival graft is required.
Yes, sir.
Okay.
Yes. Thank you, sir.
Thank you.